finished my bachelor's degree in psychology, continued to work in the field. To about maybe 7 years ago, I went back and got my master's in community counseling, which didn't really change what I do on a day-to-day basis. Kind of thought at the time that's where the field was going. I thought, well, I should have the skills to work with dually diagnosed clients. Substance use disorder is still my thing. That's still the population that I'm drawn to and that I prefer to work with. Let's see. Through all of my education and experience, I gotta say that when I'm in the room with a client or doing group, what I draw on most is the technical skills that I learned here.
Thumbs up if I could do that right now.
I tell that to a lot of people that, the in-depth one-on-one instruction in counseling skills and in counseling theories that WCTC provided me with is the foundation for everything. So, use this opportunity. You take these skills and make them you, and I think things will be easy from then on. My career route kind of, I worked in outpatient AODA treatment, then went to medication-assisted treatment for a little while, and I've been at the AIDS Resource Center as an alcohol and drug counselor, and now as the clinical supervisor for 14 years. About a year ago, after I had my second baby, I kind of did some thinking and made some changes. So now I'm only at ARSW 8 hours a week doing clinical supervision, and then independent contract at a place where I can see clients. That's why today was a little chaotic because we started IOP this morning, but we're good. I'm here.
I appreciate that.
So kind of what I heard Lisa say is that the relationships you make and the people that you meet really are valuable. Some of the opportunities that I've had at jobs was all about networking and all about kind of finding someone who you admire and you click with, right? Because we don't do this kind of work in a vacuum. Typically, we co-facilitate. We have coworkers that we need to be on the same wavelength with. So, my little introductory speech. I want to tell you a little bit about AIDS Resource Center, and then I brought some more materials about the prevention department in particular and the PrEP program. Is that something you guys might be interested in? Okay.
Curtis, the papers, Jacob. There's some extra ones.
The AIDS Resource Center is an AIDS service organization. We do a lot more than that. It is actually evolving quite rapidly as HIV and AIDS changes in the world. Some of the services that we offer: medical care, this idea of an HIV medical home. ARCW pioneered this program. It was back, Jim Doyle was the governor, so it was 8+ years ago. And that gives a special Medicaid designation to ARCW as an HIV medical home, meaning it's a place where people can come for HIV treatment, but also all these other services. So everything else that's on this list. Pharmacy, there's an in-house pharmacy, case management services, housing services. We have a couple of attorneys on staff who can help with things like disability claims, living wills, estate planning, and sometimes financial services. We have the Behavioral Health and Wellness Clinic, which is my department, food pantry, prevention services, and a PrEP clinic. I'll talk a little bit more in depth later about our prevention services and our PrEP clinic. ARCW is the AIDS Resource Center of Wisconsin. Coming in the next year, you'll probably hear about a name change. because ARCW is expanding beyond the borders of Wisconsin. In Wisconsin, we have a location in Milwaukee, Madison, Green Bay, Kenosha, Eau Claire, La Crosse, Superior, and Appleton. Not every single service is available at every location. The major ones with medical care are Milwaukee, Green Bay, Madison, and Kenosha. In fact, our Superior office has one staff member who does everything. We, 3 years ago, merged with Rocky Mountain Cares in Denver. So they have all of these services in Denver as well. And just about a month ago, we merged with St. Louis Effort for AIDS. So that's brand new, but it's a result of marketing and training that ARCW has done over the years, training different AIDS service organizations throughout the nation in how to do this HIV medical home idea. What I do primarily is substance use disorder treatment within the Behavioral Health and Wellness Clinic. Our department has a psychiatrist, a psychiatric nurse practitioner, a number of psychotherapists, and 3 AODA substance use disorder counselors. We provide services in Milwaukee, Green Bay, and Madison. We do individual therapy. In Milwaukee, we have day treatment. In Madison and Green Bay, we have intensive outpatient treatment. The difference is mostly just geographical. In Milwaukee, places still do day treatment and 12 or more hours of treatment a week. In Green Bay, the insurance companies and the kind of general treatment community tends to provide mostly intensive outpatient, 9 hours of treatment a week. We also have an aftercare group. It's actually been going strong for 3 years now with some founding members because the research indicates that the longer somebody can stay connected to some kind of service, the better chances they have at long-term recovery. Right? So our aftercare group can look a little bit different because it's people coming in with whatever their stressors might have been for that week. How do I maintain this change that I've made? And each location has slight differences in the target population. In Milwaukee, our program came about through the prevention department. We used to be part of the prevention department until about 9 years ago. In 1997, ARCW opened the needle exchange program. At the time, it was one of a handful in the nation, and it was pretty scandalous. Now it seems like nothing, but 20 years ago, it was a big deal.
Can you talk a little bit more about that? Just let them, give them a little bit more information about what you do.
Yeah. So we provide clean needles to injection drug users through the needle exchange. We ask that customers bring in their used needles, and we're always collecting like laundry detergent bottles so they can be safely disposed of and collected, and then ARCW gives them to a Stericycle, disposes of them properly. Each consumer is then given kind of their requested number of needles, some clean like cookers, sometimes water if we have it, tourniquets, and cotton. So it's funny how it works out in the population. Typically what happens now is that someone from a group of users will be the designated person to come down to the agency, bring a whole bunch of needles, and then get a whole bunch and bring them back to their friends. I wish I had the statistics, but I can tell you that consistently the number of new HIV transmissions for the injection drug using population is low in Wisconsin. And it's low in Wisconsin because of the needle exchange. There's been a slight uptick, which the route of transmission gets a little blurry because the uptick tends to be the MSM, men who have sex with men population, who are using intravenous crystal meth. So that population tends to look a little bit different. There's also high rates of syphilis in that population. So, we don't know if the route of transmission is intravenous or if it's through sex. But at the time, from 1997, we were kind of dealing with a population that wanted to make a change, but they didn't fit into normal abstinence-based treatment anywhere. If they came in and said, like, I'm using heroin and I kind of want to stop, but it's really hard and I don't have support or resources, they stuck with that. Well, to enter a program, we need you to be abstinent. Well, what do? So ARCW's program was designed to be harm reduction based. Is that something that you guys have talked about or are familiar with? Okay. So harm reduction based treatment falls in the spectrum of a lot of other harm reduction activities. The idea is everybody deserves respect as they're on their own journey. So the idea is to meet clients where they're at in order to better help reduce disease risk, reduce the risk of death, reduce harm to families. So there's, on the spectrum, there's needle exchange, there's overdose awareness, and then we provide treatment. So someone can come into our program, do an assessment and say, just don't know if I'm quite ready to quit. And we'll say, well, come on, it's our job to help you figure that out. We utilize the stages of change model. So our job as facilitators is to move someone from contemplation to preparation to action, to deal with the ambivalence while they're with us and getting support, because then the idea is there's no reason to be dishonest about your use. There's no reason to feel stigma, because if anything comes up, we're going to deal with it right in our session or right in our group. We're going to talk about why you're still using, what's the barrier to change, and what else we need to put in place to make that more likely to happen. Especially at a time when relapsing can be so deadly, right? The opioid epidemic, people get clean in jail or in detox, and they get out and they use, and they die and they overdose, right? So we can't get people clean if they're not alive. So I feel like now more than ever, our model is really a good fit for a lot of people. As our program has evolved, we see clients kind of from anywhere. So we see people who are HIV positive and get other services through the agency. And we also see anyone in the community who needs treatment. So to be in our substance use disorder treatment, they don't have to be HIV positive. They could come through the needle exchange, they could come through some court diversion, they could come through a probation officer because they have a OWI. Yeah.
So if somebody shows up exchanging needles, do you try to intercept them right there? Or do you, okay, so like, they can't just walk in, hand a bag of needles, and leave right away. You guys try to...
The conversation is had. So the prevention staff doing the actual exchange asks, are you interested in recovery information today? If so, and one of us is available, we'll run down and we'll talk to them right then and there and try to get an appointment set up. Typically, what they need help with most of all right now is getting medication-assisted treatment. We can help with that too and make referrals. It's great when it happens that way, it really is. And a lot of times people remember it. Maybe they're not ready right now, but they remember that they had an interaction with somebody at the needle exchange who talked to them about recovery. And they already trust ARCW because, the thing about here's active injection drug users coming into a facility with dirty needles and probably other paraphernalia on them, and they're trusting they're not going to get arrested, that no one's going to call them a junkie and shove them out the door. Right, so there's already a level of faith in our agency. But in working with the HIV positive population, harm reduction works really well too, because some of the older HIV medications cause a lot of intestinal problems can cause wasting, disease. So oftentimes, somebody who's HIV positive might be smoking pot. They might be prescribed Marinol. They might be doing it because it helps them eat. And that is really important to them. So we don't necessarily look at that and say, you gotta change that, right? We let them be the guide on that, you know, and we explore it more in groups. Like, is it causing problems? Are you sure it's just to help you eat? You know, we're always questioning. But in the meantime, they're able to make some significant changes to their crack cocaine use, their alcohol use, the things that are preventing their medication adherence to their HIV regimens, and overall causing the problems that drug use can cause in our lives.
Question, so the needle exchange is that just for people that are HIV positive or just anybody?
Anybody. We have on-site needle exchange, so anybody can come to any ARCW office and exchange their needles, get clean needles, even get tested for hepatitis C, HIV, and other sexually transmitted infections on site. Or they can call or look on their Facebook page, and one of our needle exchange vans will meet them someplace. We used to have more of a van was stationed in a certain neighborhood, and people knew when the van was there, so they would go to meet the van. Now we spend a couple days a week roving, going to wherever clients need us to be. And we try to gather more information if there's an overdose or if somebody gets naloxone and then ends up using it. But the philosophy around needle exchanges is that even people in active addiction have dignity.
Right.
And can make choices about their lifestyle and still take some measures to reduce harm and to protect themselves and other people. So, it can be a moral quandary, and you're asking a good question. You know, I like to think that sometimes in the scope of somebody's life, we only have a couple interactions with them, maybe even one, before they make a decision, before they kind of judge the treatment field. So if we can be welcoming at that first contact and they remember that, they're more likely in the future to come back and seek services somewhere. Rather than, you know, I went there and they told me I was still using, so they said I can't get any help, I gotta go to detox and get clean. People get a lot of doors closed in their faces, right? They try to get into detox and it's full. They try to get to residential, they're on waiting lists, or their insurance doesn't pay and they're there for a day and then they're put back out on the street. So at least we have connections to services in the meantime while somebody's on their journey towards change. Does that help?
Just like, I guess Tammy, to rephrase for her, like think of it in a different way, is she saying like, it's illegal, like, it is an illegal thing, but it's still, we still can't stop people from doing it. So the option is either let them do it behind and scold them for it, or create a safe space where they can walk in and get clean needles, so that they're not putting themselves in others in harm.
Right.
So it's not so much as condoning it as giving them a safer way to do it, because we know we can't stop it completely. And this
Right.
is step number one to recovery.
No, I get the part. I think that's great that you're giving them like clean needles instead of everybody sharing the needle. But I guess if I were there, it'd be hard to like give that needle, and yet you're trying to get them off the streets and off the drugs and into a better life. But you know, giving them the needle, they're going to go out and still do what they're doing. I guess
Well, it's because
it'd be like a dilemma for me personally.
Well,
It's
it's
about
because they're-
disease prevention, sorry, Jen.
Right.
Oh, I was just gonna say
That's the bottom line, it's exactly what she said, you cannot stop it.
Right.
Give them an opportunity to not become positive, to not move into that cycle. I mean, there's hepatitis, there's all
Right,
kinds
right.
of diseases. So yeah, it sucks because it is a moral quandary. But in my own personal life, I would rather see people that I love have the ability, if they're going to do it, God, let them be safer. And
Right.
that, I mean, there's no safest, but morally, I'd rather have them alive or not positive or not sick, and hopefully continually going in will give them the power to become in the state of mind to go to recovery. So as much as my morals say, God, that sounds so bad, I'd rather reduce disease. And so that, like, I think that's their bottom line, you know what I mean? Sorry, I didn't mean to get that.
Well, I was just gonna say, it's like, they're, from what I'm getting from it, they're more, the AIDS Research Center, they're more interested in stopping AIDS and sexually transmitted diseases. You know, that's their thing, they're not exactly there to stop the heroin addiction. I mean, they are, but, you know, they're to stop the diseases over.
Right.
Yeah.
I mean, that's not, people are gonna do heroin no matter what.
Yeah.
I mean,
Yeah, yeah.
like she said, make it safe if they're gonna do it.
Yeah. I work in the substance use disorder, treatment program at ARCW, but our overall mission statement is, our vision is a world without AIDS. So these things help, and I totally feel what you're saying. This can be a very emotional field to work in. Sometimes people relapse a lot, and in substance use disorder treatment, like, the specter of death is always there, right? So there are going to be clients whose drug of choice isn't opioids, and they're going to die in treatment. They're going to die before treatment. It's one of those sad facts that we have to be okay with, to realize that we only play a small role in people's lives, and what we can do to help is just that. We can't control what happens when they go home. We can't control what the rest of their life is going to be like. I don't want that to sound sad and defeatist, but
Oh, it's very true,
yeah,
very
yeah.
true.
Um,
So I don't know if that was the slides you want
I-
to show, or the other one,
um,
or none of them? I just put those up there so you could. Pick
Let me
one.
pull up the prevention a little bit more before we go into prep.
So the slides, there you go.
So our prevention department does a lot of things aside from the needle exchange. LifePoint is our needle exchange program. We also do counseling, testing, and referral. So that's about HIV, hepatitis C, and other STIs. We have all the services if somebody is test positive for HIV, and then typically, if they're on site in an office when they're tested, they're walked immediately to meet with the case manager, and medical appointments are made for them if they're willing. So things can happen in real time. Hepatitis C, we don't do hepatitis C treatment for someone who is not HIV positive. And there's a little bit more of a barrier to get those medications because of insurance costs, and most insurance companies kind of need to see some behavior changes before they will approve the medications because they're rather pricey, about $1,000 a pill for 8 weeks. We also distribute condoms in a variety of places, from a bowl on our desks to in some of the bars. PrEP we'll talk about in a minute, and then there's prevention programs that target men who have sex with men, trans and gender non-conforming individuals, and same gender loving men. So we have groups, we have specific outreach programs. We always have a presence at every Pride event statewide. Health fairs, you name it, they're always out doing something. And then PrEP, the big R PrEP, Personal Responsibility Education Program, is a healthy relationships and safer sex module that's done in some schools. Historically, sometimes that's abstinence-based, sometimes it's not. It depends on government regulations for the funding. So there's statewide, there's 30 prevention specialists, 3 associate directors, 1 prep coordinator, and then a navigator. A navigator walks a prep client through the process, and then ARCW does research in combination with UW-Madison. Yep, so it said test for HIV, hepatitis C, syphilis, chlamydia, gonorrhea. HIV tests come at no cost, and the results are provided within 20 minutes, so things really can happen in 20 minutes. We also have counseling and testing staff that might go to other agencies in the community and have a presence there. For a while, we had somebody who did counseling and testing in jails. So, PrEP with a little r is pre-exposure prophylaxis. That is a practice of giving someone who's at a higher risk for HIV transmission some HIV antiretroviral medications while they might be in a relationship with someone or using intravenous drugs or other high-risk behaviors. And the science has shown that if they take those medications regularly, the risk at seroconversion of becoming HIV positive is significantly declined. Does that make sense? So people can come, people who are HIV positive might bring their partners in for this. A sex worker might come in for this.
And how about cost? Because you mentioned,
It's done in 2017 and 18 positives were found. 2,000 hepatitis C tests and 139 confirmed positives. And look at the needle exchange numbers, right? I mean, people are using, and this is, we like to think that that we get a lot of the, like most of the injection drug using population, but those numbers just make a dent. Then almost 6,000 new individuals completed opioid overdose training. How familiar are you with the idea of naloxone, Narcan? Oh, go ahead.
I was asking a question. What, do they have to bring in needles to get new needles?
They don't have to, but it's highly encouraged.
Do you ever turn somebody away?
No,
Okay.
no. Staff will say, please next time, just bring in some needles because we got to get them off the street.
Okay.
Because that looks bad all over. Sometimes we've come under fire because people come to the needle exchange and they use in their cars and there's needles on the street. And that's upsetting to everybody. Once I found a needle like on the street outside my daycare and I had a meltdown. But it shows you that it happens everywhere. And whatever we can do to clean things up and, lead to kind of a more responsible population, better. So, how familiar is anybody with Narcan and naloxone overdose? Okay, so I don't want to start at the very beginning, but one of the things that we've done a number of years now, when we first started doing it, we had to have a doctor write prescriptions for the naloxone in order to get it. So we provide free naloxone, which can reverse an opioid overdose if that's what the person is using. We train injection drug users, their family, providers, anyone who wants to come in the door. And it's encouraged, never use alone, always use them with somebody who has the naloxone nearby. the data that we have on saves is really not accurate because it's based on the reports of people who come back in and say, hey, yeah, I used my Narcan. I used all 5 doses of my Narcan on somebody. But now the idea of Narcan has really taken off, and fire departments, police, gas stations,
Schools.
schools. Yeah. The training is pretty minimal. It's about a 10-minute video. I think there's a link to it if you guys would want to watch it later on.
I think it's in your PowerPoint.
I think
there's
it
a link.
is, yeah. It's a little graphic because it does show real overdoses. Any other questions on prevention? General? So this is a little bit more information about PrEP. Which is pre-exposure prophylaxis. There's always been post-exposure prophylaxis. Say somebody is in the healthcare field and they end up with a needle and stick. They'll be prescribed an antiretroviral for a short period of time to reduce the likelihood of seroconversion. So this is looking at it from a different angle.
So why aren't they providing these to, like, nurses and stuff that have the opportunity to be stuck by a dirty
Well,
needle or something?
It still does have side effects. You're still taking a medication every day. There's just some GI problems that it can cause. So maybe some employers are offering it to people who are at high risk of a needle stick. Usually needle sticks are kind of few and far between. Practice universal precautions. Can be up to 99% effective at preventing HIV. It can prevent the replication of the virus.
Is this fairly new, Pam?
It is.
Okay.
We've probably been doing this a year or 2.
Okay.
I am not a doctor or a nurse, so I'm not going to do a good job explaining some of the things, how the virus replicates. Like I said, it's designed for people who are HIV negative and are vulnerable to getting HIV. Can be prescribed for gay and bisexual men, for heterosexual men and women, for transgender individuals, and for genderqueer and non-binary people. It can also help people who inject drugs to HIV negative. PrEP is recommended for people who don't always use condoms, who don't always ask a sexual partner or have the power to ask a sexual partner to use a condom. They have been diagnosed with a sexually transmitted infection in the last 6 months, unsure about the HIV status of your sexual partner, in a relationship with someone who's HIV positive, who may or may not be on treatment, a person who injects drugs, or in a relationship with someone who injects drugs. The HIV research is pointing to this idea that undetectable is untransmittable. I'm probably not going to do a good job explaining it. To be considered undetectable, the number of HIV virus cells in your body has to be below a certain number, and the number of T cells has to be above a certain number. So that means the virus is still kind of in your system, but undetectable means it's barely there. If someone is undetectable and taking their medication daily, stays undetectable for 6 months, the CDC is now considering that person to be unable to transmit the HIV virus. There's always chances, and there's always times that medication might slip up or there might be interactions, but that's what the CDC is saying now. So that's more is going to come about that, and as more research is done. But that's very empowering for someone who may have been positive for 20, 30 years.
So we are run out of time, but I want to thank you so much.
I'm sorry for being all across the board. There's a lot to talk about.
Yes, I will select those. Let's see.